So I'm going to now talk sort of back-to-back about AFib and then about stroke prevention. All right. So AFib, everyone here has seen. The activation of the atria in AFib is different from most everything else in that every wave of activation throughout the atrium is sort of different from the preceding one, and so it leads to a very irregular rhythm, very irregular activation if you have electrodes recording from these signals, very fast activity, and basically chaos. The diagram over here, the animation wants you to look over here that there's a very fast, regular firing over here that then is breaking apart elsewhere. And that's on purpose. In 1998, Michel Hassaguer figured out that the pulmonary veins oftentimes trigger atrial fibrillation. He basically had electrodes inside this patient's left superior pulmonary vein over here, and he found at the initiation of atrial fibrillation a spot deep within the vein over here. This is the left atrial border, was the first to fire, and it exited through this portion of the vein and then triggered the AFib. So AFib is associated with stroke. It doubles the risk up to increasing the risk by tenfold, depending on the risk comorbidities. It's also associated with an increase in mortality. It is, in the newest data, it seems potentially related to dementia risk. Whether we're talking about Alzheimer's dementia or vascular dementia or sort of nonspecific dementia, the chance of achieving that diagnosis in your lifetime is greatly increased if you also have the diagnosis of AFib. That doesn't prove causation, but that's suspicious. The patients who have AFib, right now there's about 3 million Americans, but that may close to double over the next 30 years through the aging of the population. There are definitions you need to know for the boards and for practice. Paroxysmal AFib and persistent AFib and long-standing persistent AFib, we treat these very differently. And it's sort of useful to know where your patient sits, and it's useful when you diagnose a patient of AFib and you put that as your assessment. The next word after AFib should be one of these letters, one of these phrases. So if a patient has paroxysmal AFib, that means their episodes are never longer than a week. Once you have an episode lasting longer than a week, you're basically sort of lumped into the persistent AFib category. And then if you've had AFib for 12 months continuously, we call you long-standing persistent. And if you have any form of persistent AFib where basically everyone has mutually decided that we're not going to try to get you out of it, then you're basically permanent AFib. And then valvular AFib is AFib in the setting of rheumatic heart disease or a prosthetic mitral valve. So our treatment goals in treating these patients is to treat symptoms primarily. In the second part of this whole talk, I'll talk about stroke prevention, and that's, of course, really almost the most important thing. But in terms of treating the rhythm or the rate, the main goal is to treat symptoms. And a secondary goal, if we can achieve it, is to improve outcomes, of course. The improvement of symptoms is very clear-cut. Improving outcomes, the data on that is a little bit, it's not like there's yet a randomized clinical trial that gives us that data, but that data will come soon. Rate control in the 2014 guidelines. So in 2014, the ACC/AHA and Heart Rhythm Society published in JACC guidelines for treatment and management of AFib. That's been there long enough that certainly is on boards and things like that. The rate control recommendations, class 1 is, you can use beta blockers, calcium channel blockers. These are all fairly straightforward. AV node ablation is on these guidelines, is something you can consider as a last resort. And then, of course, you shouldn't use beta blockers, calcium channel blockers, et cetera, in pre-excited AFib. So cardioversion, the guidelines here are sort of probably what you're all practicing, but there's one thing that will change in the next version of the guidelines, almost definitely. So in clinical practice, probably most of you, if you've been trained that if a patient has AFib of less than 48 hours you can cardiovert them without necessarily having had them on anticoagulation, maybe even without doing a TEE. And that's been sort of dogma. In earlier this year, in an article by the late Mark Josephson, there was an editorial based on a study of 5,000 European patients followed after cardioversion. All of them were low-risk patients, very low CHA2DS2-VASc score, patients with AFib of less than 48 hours who got a cardioversion. And the stroke risk after cardioversion within a month was 0.7%. So not scary high, but 7 in 1,000 is enough that if everyone does that, 10, 15 times in a year, you're going to have a patient have a stroke that could have been prevented. That's not acceptable. So the new version of the guidelines will probably change this. This is the recommendation over here with AFib or flutter less than 48 hours and low risk. You can potentially use no antithrombotic can be used for cardioversion. So Wilson already went over this slide in terms of the choice of drugs for rhythm control. One of the more basic questions is what the heck is AFib? What causes it? What's the pathophysiology of AFib? And honestly, we don't know. It really boils down to it could be a lot of things, and we don't really have a good theory of AFib, which is sort of surprising but true. The three theories of AFib right now are that it's an autonomic cardiac autonomic neuropathy. So basically there are parasympathetic ganglia that encircle especially the left atrium, but also the rest of the heart, that have influences on the underlying atrial cardiomyocytes that are clearly afibogenic, in that they alter the electrophysiologic properties of these cells when stimulated in ways that conceivably would make people go into AFib. In dogs and other animals, if we simultaneously stimulate the vagus nerve and the sympathetic chain, we can induce AFib in animals that otherwise would not be easy to make go into AFib. There's clearly some role to this. Ablation and treatment strategies targeting this are sort of still being worked on, and it's not clear that they work perfectly. There's a theory that AFib involves lots of reentry. Basically, there can be rotors, spiral waves, micro reentrant flutters. Basically, with lots of scar inside the heart, it's possible in certain areas for a wave of electricity to start going around something like it would in a flutter, but now in small areas. And those then, when you have more than one of them, sustain AFib. And then there's theory that basically AFib is just triggers. There's lots of different areas, especially the pulmonary veins, as we just showed, that in patients with AFib just tend to fire fast and breakup of the wavefronts out of these areas results in AFib. And then the truth is somewhere probably in between all of these, where there's every one of these mechanisms playing some role, different roles in every patient. The ablation strategy for managing AFib, the cornerstone of it is really based on the work of Dr. Asseguer to isolate the pulmonary veins. Pulmonary vein isolation involves encircling the 4 pulmonary veins with some number of lesions so as to make it impossible for any wavefronts to enter or exit those pulmonary veins. And there's a lot of ways to do that involving lots of variations on simple geometry. So you can kind of draw circles around each of the 4 veins, circles around the pairs of veins, a box around everything, or all of the above. And then for patients who have more and more persistent AFib and greater disease, possibly or probably other strategies need to be added to this in terms of addressing flutters, trying to find various triggers and burning them, potentially ablating these parasympathetic ganglia. So in terms of what you think the mechanisms for particular patients' AFib are, whether it's more autonomic or ectopic foci or various triggers or sustaining mechanisms like rotors, we have various forms of ablation that target that. In general, how well does ablation work? Ablation definitely works better than drugs. So in terms of symptomatic atrial arrhythmia, In this slide, these patients were on drugs, and these patients had an ablation procedure, and patients who got the ablation procedure were much more likely to be symptom-free after 9 months. And this was significant, and this has been seen in many, many trials. The embarrassing part of this is that drugs have a very low efficacy. The antiarrhythmic drugs as a total have a low efficacy. In general, even amiodarone long-term use has about a 65% reduction in AFib burden, so on average with lots of people. And ablation is better, but it's still not where we'd want it to be. Like, we would want it to be close to 100% or 95%, and it's still really below 80%. Can ablation be used as first line? A number of studies has looked at that. So if a patient has AFib, consider ablation instead of even trying a drug. And it can work. In general, the patients who got ablation were more likely to have a decrease in their symptoms from AFib than those in drugs. Blue means you didn't have any AFib on a 7-day Holter at various time points from ablation or drug therapy decision. And this study, basically at every point, there were more patients who got ablation who had no AFib than on drugs. So if that's your goal, then ablation works better than drugs. In terms of the amount of AFib, the patients who got ablation, 90% of them had a burden of AFib, the percent of each day that's in AFib, of less than 9%, whereas for drugs, 90% of them had an AFib burden of less than 18%. So it decreases AFib symptoms better than drugs, decreases AFib burden, and it produces a much higher, a higher chance of being completely AFib-free. The AFib recurrence is also delayed if you get ablation compared to drugs. So in terms of symptom control, if that's our goal for treating a patient, if patient's coming to us and they feel bad when they're in AFib and their exercise tolerance and everything else is not ideal, as first-line therapy, AFib ablation can be considered instead of drugs. But really, the take-home message from this is drugs can work, and drugs can, in some people, work fairly well. If a patient has tried a drug and has failed it and still has a lot of symptoms, ablation is clearly a much better option than trying more drugs or different drugs. Complications from AFib ablation are basically mostly related to bleeding, and in particular pericardial bleeding and tamponade, 1%. Stroke risks have come down now that we're doing the procedure almost always on anticoagulation, on full anticoagulation, with cardiopulmonary bypass level heparin. And so that's lower probably than this, which is historical. Atrioesophageal fistula basically comes from damage to from the proximity of the posterior wall to the esophagus. You can imagine burning there can damage the esophagus. That can be lethal. People die from this. This is really the only mechanism of death. Fortunately, it's 1 in 10,000 risk and less nowadays. There are a few other complications, including phrenic nerve paralysis. If you say patients who say they can't breathe and they had an AFib ablation a few months ago, among everything else, a chest X-ray may tell you if their diaphragm is elevated that maybe someone burned the phrenic nerve or more likely froze the phrenic nerve. So in terms of goal number 2, improving outcomes, that's really, when we put stents in people or do bypass or things like that, we really do it to improve outcomes. It would be really nice to have that level of data for AFib ablation. And we're getting that data. In this study from 2013, patients who, and this is involving tens of thousands of patients in Utah, basically patients who had AFib but did not go through an ablation were compared to patients who had AFib, who did not have AFib. And basically, some of these patients had low CHADS-2 scores, some of them had high CHADS-2 scores, but regardless, and all these patients were being treated by cardiologists, regardless, your risk of stroke was higher if you carry the diagnosis of AFib than if you didn't have the AFib diagnosis. And it was twice as high as it would be, regardless of CHADS score, as someone similar to you who didn't have AFib. Whereas in this same study, taking those patients who were diagnosed with AFib but had undergone ablation procedure, These were compared to matched controls. The ablation procedure, those patients wound up having the same risk of stroke as people who didn't have AFib. Whether, and this has all the hazards of retrospective studies, whether these patients were more likely to be on blood thinners than some of the people who did not go through ablation, all of those things could play a role here. The CABANA trial has finished enrollment. This is a large trial that's enrolled something like 5,000 patients across the world. This trial will come out probably in a couple of years. They're following the patients right now. This will provide probably the outcome data that we want to see. So what do we do for a given patient? If a patient comes to you and has symptomatic AFib, or what do you do? Usually, it's an individualized decision. If a patient is very symptomatic, that increases your desire to treat them, potentially even with ablation first line. If a person has very little AFib, that alters the equation a little bit. If they have structural disease, if that affects your anti-arrhythmic drug choices and your desire to get them on the ablation table. And how much AFib, if they're in persistent and whatnot.